Good evening, everyone, or good day, depending on when you're watching this. This is your video review preparation for exam 2 in 1201. All right, let's get started. So you will want to review GABA. What does it do? It is the amino acid neurotransmitter that's believed to be dysfunctional in anxiety disorders. GABA reduces anxiety and norepinephrine increases it. So review those chemicals and know what they do. The best thing that a client can do for any type of mental illness or really any type of situation that they're seeking treatment for is to do medications and therapy. A lot of clients will want to do only one or the other, but it's really most effective to do both medication combined with therapy. That will create the best change. You'll want to review some of the behavioral therapies that are talked about in your textbook. For instance, if someone has a phobia of, let's say they're afraid of dogs, what is it called when they are gradually introduced to dogs? That is systematic desensitization. That can be used for flying. A lot of people have used that for flying. If someone has a fear of flying, there actually used to be a program that you could enroll in. I think it was very expensive, and it took place at the airport, and you would go meet at the airport and have like a group therapy just there at the airport. And then after several sessions, you would sort of walk to the gate of a plane, and then maybe a couple sessions more, you would walk onto the plane, and then you'd walk onto the plane and the plane would start. So a very gradual, systematic desensitization. So review more on what that is. When a client is experiencing a panic attack, the priority is safety. You want to keep the client safe and you want to assure them that they are safe. So the most therapeutic response by the nurse is telling the client, you're safe, take some deep breaths. You never want to tell someone to relax. Please don't ever say, oh, relax. That never works. Does it? I know someone has said it to you at some point, but that doesn't work. So don't say that, but you want to reassure someone that they're safe. You want to review post-traumatic stress disorder. What is it and how is it different from generalized anxiety disorder or acute stress disorder? So make sure you review those and know examples of each of those. When a client is learning to cope with anxiety and stress, you're not ever going to change the stress, the external stress. So for instance, let's say someone is feeling really stressed. You can't really just tell someone, well, just decrease the stress in your life. We don't really have control over a lot of our stressors, like taxes or school or, a large family or no family. There's just stressors that just are. But what we can change are the reactions to stressors. So it's not realistic to advise a client to just decrease the stress in your life. Well, not everybody has the privilege to do that. Some people they live where they have to live, and their life is what it is, but they can change their reaction to it. And that's the most ideal thing to do. You want to review some of the different phobias. So things like agoraphobia and claustrophobia, make sure you know those definitions and what they are. Agoraphobia, of course, is a fear of open spaces, so the client won't want to leave the house. Things like misophobia is a fear of dirt or germs. I know some people use the slang germaphobe. That's not the thing. It's misophobia. Claustrophobia, of course, is the fear of enclosed spaces. Acrophobia refers to a fear of heights. You can think of acrobats to remember that. So know some of your phobias so you can answer questions about those. Assertive communication. I think we talked about this earlier in the course, but we're talking about it again. Again. Assertive communication is using I statements. So when you're late, I feel disrespected. That's assertive communication. You can always identify it when you hear the I statements. I guess more on post-traumatic stress. Make sure you really understand post-traumatic stress syndrome. When someone has obsessive compulsive disorder, they know the behavior that they're doing. They are aware of it. So I don't want you to think that they don't know what's going on. If they're washing their hands compulsively, they're aware that they're doing it. They really can't help it. They're acutely aware of their compulsions. And they're very upset over the control that these compulsions have over their lives. You want to review the different OCD behaviors, especially the behaviors that are physically destructive, like dermatillomania is skin picking. It is a self-soothing behavior. Trichotillomania is hair pulling, and they'll have bald spots. Usually it starts in the back of the head, and they try to hide it, but eventually the bald spots will show. Onchophagia is nail biting. That's also a self-soothing behavior. So those are the ones related to the body. You should know some of the other compulsives, like kleptomania is compulsive stealing, and oniomania is compulsive buying or reward-seeking behaviors. So it's like compulsive spending. So review those terms. When you're treating someone with OCD, we're not going to cut off those behaviors, but we are going to very gradually decrease them. So let's say someone comes in, they're admitted for compulsive hand washing. They wash their hand, 100 or more times a day. The treatment plan might be, okay, tomorrow we're going to try to wash our hands 95 times in the day instead of 100. So it's a very gradual decrease, and it's never going to be discontinued. They don't have to stop washing their hands completely. The goal is to just get the patient to the highest level of functioning. So they can still wash their hands, and they can still wash their hands a lot, as long as they can maintain a job, take care of themselves, and have a healthy, happy life. But the OCD is not going to go away completely. Always remember your physiological priorities and Maslow's hierarchy of needs. That is all still very relevant in mental health. So there are some questions on physiological priorities. So if you need to review that, please do so. When someone has anxiety disorder and you're recommending some stress management techniques, you always want someone to practice those techniques when life is good and when they're calm, because that way it becomes easier to incorporate those techniques in times of stress. But the first, when someone is really stressed, that's not the best time to try something for the first time. You want them to really do the things when they're calm, so that it's easier for them to implement when they're stressed. I hope that makes sense. And a nurse can absolutely teach those type of techniques, deep breathing, or just, stepping out for a slow count to 20, things like that. It's hard to do that in the heat of the moment, so we want people to practice it when there's not a lot going on. Okay, I know that Dr. Hall, remember back to level 1 when Dr. Hall taught you dressing change, and remember how she taught you to remove the dressing away from the patient's face. That has several purposes. It helps to prevent the spread of infection, because you don't want someone breathing right there on their wound. But also, you don't want the patient to see their wound in case it's upsetting to them. Of course, they're going to see it eventually. But, you don't have to start with it, unveiling it towards their face. So you were taught to peel the dressing back away from the patient's face. So what happens if the patient starts feeling really anxious? You can immediately put the dressing back down and address the patient. You don't want to ignore the patient who is now having increased anxiety and continue on with the dressing change. Put the dressing back down. Now, this is assuming that you haven't already removed it, right? You're going to start to peel it up. Patient starts going, oh my God, and starts freaking out. You just put it back down and address the patient. Help them relax. Maybe talk to them a bit. Explain again what you're going to do. Do some patient teaching. Maybe they don't want to see the wound. And so maybe they want to have a washcloth over their eyes, or just hold something up, or maybe you want to put a barrier up or something. But you can address that if you just put the dressing right back down. The priority is to lower the client's anxiety level, because if you get the dressing off and the patient starts becoming very anxious and goes into a panic attack, then you risk the integrity of the wound also. Okay. You should review nursing theorists that are related to, that developed interpersonal theories regarding anxiety disorders. And that's Henry Stack Sullivan and Hildegard Peplow. These are two really big names that you will learn about in detail when you go on for your RN and higher degrees. But they are really big nursing theorists, so please do review those theorists. Also, throwback to level 1, please review Cellier's general adaptation syndrome. It is important that you know the stages of adaptation syndrome and that is alarm, resistance, and exhaustion stages. Remember, is that ringing a bell? I think it was in 1204. So if you think about someone who gets into a fender bender, maybe you've gotten into a fender bender or something bad has happened. There's this alarm all of a sudden, right? You're shocked. Oh my gosh, someone just hit my car. And then there's the resistance stage where your body is trying to cope and your mind is trying to cope. And then there's exhaustion, right? If you think about something that happened to you, at the end of the day, weren't you just exhausted? It's really tiring to be stressed. So important that you know that so that you can understand what a patient is going through when they have had a trauma. Maybe you're treating someone who has had a car accident or some sort of trauma, and they're asking you, why am I so tired? I just don't know why. You can say, it's your body's way of handling the stress, that general adaptation syndrome. Okay, let's see. You also covered schizophrenia. So, of course, there's a section on schizophrenia. I will say again, review Maslow's hierarchy of needs. You will always prioritize care and assessment according to the hierarchy of needs. You have to address physiological needs, assessing fluid intake and output and food and sleep, all of that before anything else. You want to review some of the antipsychotic medications, and those first generation antipsychotic medications can cause tardive dyskinesia, so you want to review that term and know what it is. That it's some permanent involuntary movements. They generally don't go away. There's medication that can help calm those movements down, but very often they are a permanent thing. And so, people ask, well, why would anybody want to take antipsychotic medications if they're giving someone Parkinson's-like movements? Well, you have to weigh the benefits and the drawbacks. If someone can have decreased auditory hallucinations and have a functional life, live on their own or live in a group home, but they have some hand movements, well, the trade-off is, they might want to live with the hand movements because they can still live independently. So, that's where we kind of consider, is the benefit worth it? You want to review some of the signs and symptoms of schizophrenia, things like thought blocking. Make sure you know what that is, or thought broadcasting, or thought insertion. You should know what all of those terms are. You will have to, as a nurse, you'll have to assess clients for those things. So if somebody stops talking in the middle of what they're saying, that can be thought blocking. They just stop just like that. But for like a minute, for kind of a long time. If they say that others can hear their thoughts, that's thought broadcasting. They think that their thoughts are being broadcasted to others. If somebody is saying, I know you can hear what I'm thinking, that's thought broadcasting. They might feel that other people can take their thoughts. That's thought withdrawal. or that people are putting thoughts in their head, and that's thought insertion. You should review all of those terms. When a client is experiencing hallucinations, be it auditory or visual or whatever type of hallucinations they are, you want the a realistic goal is that the client will increase their orientation to reality gradually. The voices might not go away. Generally, sometimes they just don't ever go away. But if you can help a client realize or understand that the voices aren't real, there's not actually someone standing next to them whispering in their ear, that's a big step forward. So if they can have some realistic perspective on it, that's a win. You want to present reality to a client, and what that means is it's planting a seed. So if a client says, let's see, the CIA is telling me I need to stay right here for the next year, and they're telling me that now. You could say, I understand that you hear a voice. You and I are the only ones here. I don't hear a voice, but I believe that you do. What you're doing is acknowledging what the client is saying. You're validating how they feel and what they're saying. And you're introducing the fact that there's no one else there and maybe those voices are not real. And so that can be a very effective way to introduce reality. Okay, you want to go over some of the different types of delusions, and definitely review different types of movements. We talked about tardive dyskinesia. Also, akathisia is also very important to understand, and you'll see that when people will say, I feel like I have ants in my pants, and they just cannot sit still. They're shifting in the seat, they're moving all over, they're just fidgety. They can't help it. That is akathisia. Okay. If a student nurse is feeling fearful on a psych unit, then it's good for the student nurse to stay in an open area while talking to clients. We don't want anyone on a psych unit who is afraid. That's not therapeutic. They will not be able to be therapeutic. It's not good for them and it's not good for the clients. So, maybe the person who feels fearful on a psych unit needs to step off. Maybe they just need to stay in an open area. Maybe they need to talk about and debrief their feelings. Whatever they need to do should be done. No one should ever be forced to work in a locked area if they're fearful. You want to review some of the medications. If someone is telling you that they don't want to take their meds, rather than say, oh, okay, and put them away and walk away, you want to ask, what is it about the medicine that you don't like? Because very often you can work with a client on a solution. Let's say someone takes medication in the morning and they say, well, I don't want to take it. And you say, well, what is it about the med that you don't like? And they say, well, it makes me tired. Well, maybe you can get the order changed so that they receive it at night. Maybe they feel nauseous. Maybe you could get it changed so that it's given after a meal. Maybe it keeps them up at night. You could get it changed to be given in the morning. I think we had a similar question in level 1, but it's a good reminder to always ask the patient what's going on, what don't you like about it, because then you can try to work together on a solution. You want to review neuroleptic malignant syndrome. It is life-threatening. If somebody develops neuroleptic malignant syndrome, they will need to go to the intensive care unit. It sometimes leads to them being on life support. It's a very, very serious condition. I really want you to look it up, so I'm not going to tell you a lot about it here. I'm just telling you, please look it up. It is life-threatening. It's crucial that you understand what it is, what are the signs and symptoms of it. And I will tell you that if you suspect it at all, that person has to go immediately to the hospital. Let's see. Personality disorders. You want to review the personality disorders. I know it was a lot, but review the personality disorders and think about what would be most appropriate for people with different personality disorders. For instance, schizoid personality disorder. Where could they work? They would probably want to work somewhere that's not very busy or chaotic, not around a lot of people, something like that. So, think about those type of things. I'm just saying, review all those personality disorders. You want to be very matter of fact with clients who have paranoid personalities or antisocial personalities or narcissistic personalities. They won't understand innuendo at all, so just be very matter of fact so that there's no misunderstanding. They need serious, straightforward approach that includes limit setting and a matter of fact approach. When someone has attention-seeking behaviors, you want to teach them social skills, what is appropriate, what's not appropriate, and you want to provide factual feedback about their behavior. For instance, if someone has histrionic personality disorder, so this is the person who might be in the family practice waiting room, and you tell this person the doctor is running behind, it's probably going to be about another 20 minutes, and they have a full-on meltdown in the waiting room, you will have to say, screaming in the waiting room is not appropriate. I'm going to have to ask you to wait outside. If you're going to be this loud, you're upsetting other people. This is not appropriate behavior. Just very matter-of-factly. You do have to provide feedback because people with like histrionic personality disorders are not going to have that insight. So, teach social skills. If a patient is trying to manipulate staff, you want to set behavior limits, identify consequences, and identify expected behavior. For instance, if let's say a patient is going back and forth between several staff members, they ask you for a medication and you say, I can't give you that medication, it's not time yet, you could have it in another hour. And then they go ask another nurse and another nurse. And this is an attempt, we call this staff splitting. You see kids do this between parents. So patients do it between staff. So you want to state the behavioral limit. Please only ask one nurse. If you ask more than one nurse, the information could get confused and a mistake could be made with your medication. So you want to give all the consequences. And, we do expect you to communicate with the nurse that's assigned to you, and you will receive the medications as ordered by the doctor. So you just got to be really matter of fact and state the expectations. Again, review personality disorders and similarities between different personality disorders, like what personality disorders have a lack of caring about others? Well, that would be antisocial personality, narcissistic personality, maybe schizotypal personality. So you want to, make sure you understand similarities and differences. You want to look at some of the treatment techniques that are used for people with borderline personality disorder or personality disorders in general. One of them is cognitive restructuring, so you should know what that is. You can look that up in Vitabec and have a basic understanding of when that can be used. Let's see, more on there's a lot on personality disorders here. Maybe make flashcards of all the personality disorders so that you can memorize those. It can be very frustrating to work with people with personality disorders, and I think when practitioners feel frustrated, they really should lean on their peers and debrief and discuss frustrations with a colleague or supervisor in private, of course. But that's, you should always have somebody at work that you can debrief with so that you're not holding things in, because I think clinical staff needs to process emotions also. So I hope that you will all find somebody to process emotions and events with. Don't always go home and dump it on your family. Have some professional colleagues and mentors that you can talk to. When you're working with people with personality disorders, you will have to set very firm boundaries and really be really consistent with the rules. If you let somebody bend the rules just this once, it's gonna go sideways really quickly. So try not to do that. You want to review factitious disorder and malingering. Make sure you know those terms. Very common terms in the mental health setting. With malingering and factitious disorder, people are willfully controlling the symptoms as opposed to somatic disorders. People are not purposefully controlling anything. Have an understanding of Munchausen and Munchausen by proxy. When you're treating someone with somatic symptom illness, A goal is that the patient will be able to verbalize their emotions, because a lot of somatic symptoms are closely tied with their emotions. When they feel stress, their pain increases. Let's see what else. You want to review somatic symptom illness and what some treatment outcomes will be. You want patients to be able to carry out, activities of daily living, self-care activities. You want them to eventually identify the relationship between stress and their physical symptoms, and as I just said, verbalize their emotional feelings, and also have some ways to deal with stress, anxiety, and other feelings. You should review the chapter on somatic symptom disorder and somatization in Vitabec, and what can happen to someone who has somatic symptom disorder. Real symptoms can begin. So let's say someone always feels nauseous, and we know that their nausea is tied to stress, right? A lot of people feel nauseous when they get stressed. This is the age-old thing of like kids have a stomach ache when they have to go and do an exam or something. Maybe you get a stomach ache. Anyway, so real symptoms can begin, like maybe they get diarrhea or start throwing up, or real symptoms can continue. Real symptoms can get worse, and unrelated symptoms can occur. What if somebody has stomach pain related to stress and they start throwing up? It leads to them throwing up, right? A lot of people throw up when they feel nervous, but then they get ulcers from throwing up. So yeah, unrelated symptoms can occur. Maybe they'll get headaches, maybe they'll get dehydrated, and that's no longer related to the stress, but it's all related. But so somatic symptom disorder can absolutely lead to a lot of other things. Psychosomatic illness can affect a lot of other illnesses that a person has, such as diabetes, or, stress can raise blood sugar. It can raise blood pressure, so it can affect hypertension. It can cause headaches. It can cause an exacerbation of colitis. It generally does not affect disorders of bones, though, like arthritis. It's not going to make your arthritis worse, but all of those other disorders can be worsened. Also review the definition of hypochondriasis. It's illness, anxiety disorder, and it's a preoccupation with being sick. That's the person who is doctor shopping. They are totally convinced that there's an illness, and they'll see doctor after doctor after doctor until somebody tells them that they have the illness. So definitely review that in Vitabec also. Okay, that's it. If you have any questions, don't hesitate to reach out. And okay, that's your review for exam 2.